So, I'm Dr. Aishwariya, and I'm going to be talking about tobacco use in special populations. So, the objective, I hope, with this session, we're able to recognize unique challenges that we encounter with adolescents, pregnant and lactating women, and the elderly. That's the three special population groups that I'll be focusing on. And also, perhaps, have a discussion about the kind of interventions that we can do for these individuals and how they can be different from perhaps populations that we encounter more commonly. So let's talk about why we're talking about tobacco. And I'm sure we've read this, and I know that you all understand the public health implications of tobacco use per se. But again, to bring it to perspective, we know that tobacco is going to kill up to half of the users that do not quit, and it kills about 8 million people each year. Around 80% of that world's population that uses tobacco actually lives in countries like ours. And because it is a leading cause of preventable deaths and a major risk factor for a lot of diseases, including cardiovascular and pulmonary diseases, it's something that we shouldn't stop talking about. And when we now talk about special populations, especially adolescents, pregnant women, postpartum women, and elderly populations, they face certain unique challenges, certain health consequences that perhaps do not apply to others. There is also implication in its initiation, the maintenance of use, what are the risk factors for use. It, of course, has direct and indirect influences on the body and mind. And there is a need for effective evaluation and tailoring the management approaches a little bit. So let's first talk about tobacco use in adolescence. And I'm sure you've probably talked to a lot of people who have are current tobacco users. And what we know is that the prevalence of tobacco use in adolescence is somewhere between 11 to 17%, with slight higher prevalence in high income countries and definitely more among males. We also know that nearly 9 out of 10 adults who currently smoke had first tried their cigarette before the age of 18. So a lot of our individuals who are probably coming in today were people who were exposed to tobacco when they were adolescents. And in 2024 in the US, they found that an alarming 88% of students had actually used an e cigarette in the past 30 days. And this is the information from the National Youth Tobacco Survey. There's also Monitoring the Future and other surveys in the US, which have shown that there's an uprise, in the number of people who are actually using electronic nicotine delivery systems. Uh, and that's probably something that we also have to focus on in the coming years. So when we talk about tobacco, we're going to be talking about smoke tobacco, smokeless tobacco, which includes, chewable tobacco, snuff, etc. And we're also going to talk about electronic nicotine delivery. So I hope that we can cover this entire thing whenever we say tobacco use. Why adolescence is such a vulnerable period is perhaps there are few elements to it. I think one of them is that the brain is still developing and there is a neurobiological vulnerability. The prefrontal lobe and certain areas of the brain which are involved in decision making and in judgment and in evaluating the riskiness of a situation, those areas are not fully developed until perhaps the early 20s. And because of that, the adolescence is a period where the individual gains a little bit more freedom, a little bit more exposure, but also the brain perhaps is not able to fully grasp the consequences of any positive or negative behavior. And perhaps that is why this is an area that is very often targeted in prevention programs, because not only do people get exposed to substances at this time, but also if exposed, then they are more likely to, have problematic use later on in their life. So the earlier the exposure, the worse it gets. And that's why a lot of prevention programs also focus on delaying this process. And of course, we have the biological mechanisms by how this happens, but we also have certain other psychosocial mechanisms by which adolescents probably get exposed to tobacco. And that could be anything from peers, it could be parents smoking at home, it could be the influence of social media and how perhaps tobacco campaigns are run and how it's portrayed in popular media. So if some very probably influential celebrity is using tobacco and there's an impressionable youth, perhaps they would be more willing to try it next time. There's also something called the gateway hypothesis, and I've put it here because tobacco is one of the first substances that comes in this cycle of using substances. So we call it gateway because tobacco perhaps provides a gateway, or paves the way for use of certain other substances later on in life, which are probably more illicit, more harmful. And that's why tobacco, again, plays a very important role here. There's also the role of the family, of course, the norms in the society, the norms in the family itself. If perhaps they know that their parents would be okay with smoking, or if the parents themselves smoke, then the individual would be, entirely different from, say, a community where it's probably not approved, right? There's a huge role of the environment, and that includes the school. It includes all of the individuals that the adolescent comes in contact with. Why this is important is because when someone gets exposed to tobacco early on in their life, they obviously get exposed to tobacco for much longer. So there are long term consequences, not only on the body, but also on the mind. So perhaps there is receptor sensitivity changes, which actually predisposes certain individuals to then use different drugs, like I talked about in the gateway hypothesis. There's also, of course, the accumulated effect on the body, on the lungs and in the heart and various other organs of the body. There's a higher risk of dependence, like I said. So if someone starts early on in life, then the risk of problematic use is much higher. And then, of course, there is also an implication in, we talk about how substance use per se probably predisposes certain individuals to mental illness and other conditions, related conditions later on in life. So there is an impact at a period which is probably very, very sensitive, very vulnerable. And that's why it's important to, assess, ask for, and advise and help in any way possible if an adolescent is using tobacco. So, what are the possible interventions that we could do for adolescents? Now, of course, the usual things that we kind of do, which is pharmacotherapy and psychosocial interventions that we do for pretty much anyone who's using tobacco, including the 5 A's and all of those things apply. However, couple of things that we can do a little bit more in this population is school-based prevention programs. And why this is important is perhaps because that's where the adolescent spends the majority of their day. And they also meet a lot of their peers. A lot of their interactions happen in the context of their school. So maybe that could be one, good way to prevent or at least educate adolescents about the risks of using any form of tobacco, and also the benefits of not using tobacco. I think that adolescents are also individuals who are largely connected to their systems, very much so. So they haven't really, formed a system of their own. They rely on a lot of the institutions that they're a part of. So that could be family. So involving the family in that, involving their school teachers in it, involving their peers in it. A lot of the psychosocial interventions that are focused on adolescents actually focus on building these networks. Of course, nicotine replacement is a very viable option. Medication, including bupropion and varenicline, there are randomized controlled trials which have used adolescents above the age of 13, and they have actually found that they're quite effective at, improving quit rates in adolescents. I also want to talk about MI and CBT, which I'm sure a lot of you must be familiar with. But I think one of the things that we can do at a macro level, so when we actually zoom out and think about the society at large, there are a lot of things that can be done at the level of policies and legislation, banning taxation, banning advertisements, and probably the kind of social messages that are put out in the public that influences an adolescent's mindset quite a bit. So that's another intervention that we could do. Not maybe not, at our level, but that's something to think about. So I will now quickly go into tobacco use in pregnancy and postpartum. What we found is, especially in the National Family Health Survey 5, is that tobacco use in currently pregnant and lactating women in India is 2.5 to 3.2%. And more than 85% of these women are using smokeless tobacco. So that's probably the most popular form of tobacco that is used by Indian women. And the age group that's most affected is 30 to 34. Now, when you look at this percentage, 2.5%, it might look like a a low small number, but when you look at the population size that 3.2 or 2.5% is talking about, then that's quite large. And we must remember that this is the percentage in a special population. This is not all of the women, but currently pregnant and lactating women. So that number is quite large. And the global prevalence of smoking during pregnancy is about 1.7%, with the highest prevalence being in the European region and the lowest being in Africa, and we're somewhere in between. And over 70% of women who smoke during pregnancy actually smoke daily. As with most people who are dependent on tobacco, it's going to be a daily use of tobacco, which of course has a lot of implications in the health of both the mother and the child. So, why this might be is probably because, of course, pregnancy and lactation is a time of stress for the mother. It could also be related to the kind of support that they're receiving. A lot of myths and misconceptions. So, some people say that perhaps smokeless tobacco is quite safe in pregnancy, whereas cigarette smoking is not. A lot of people might think that vaping is quite safe in pregnancy. And in fact, that if I want to quit, then I shouldn't go cold turkey when I'm pregnant, or I shouldn't take medications to stop smoking when I'm pregnant, because that could have a much larger impact on me and my child than the smoking itself, right? So that could be one of the reasons. It could also be because they're already dependent users. So they've already established a lot of patterns and habits in the way that they consume this substance much before they knew that they were pregnant. It could be an unplanned pregnancy, and they could know about the pregnancy much into their gestation already. So someone gets to know about their pregnancy maybe a month and a half after their conception, and by then the infant is all I mean the fetus is already exposed to tobacco smoke. So there can also be a risk of that, because sometimes, and that's actually the first trimester is actually the most sensitive period, and then we've already exposed the fetus to the smoke because we didn't know that we were pregnant, right? So, what are the risks? And when we talk about the fetus itself, there's a risk of it being low birth weight. It could be born much before time. There are lots of reports on orofacial clefts. There's a lot of morbidity and mortality just around the delivery period. And there's also a risk of something called SIDS, which is the sudden infant death syndrome. And for the mother, there can be a miscarriage. There can be an abruption of the placenta, which connects the mother and the child. And there's also an elevated risk of hypothyroidism. Also, when the mother is then subsequently feeding the child, nicotine does transfer via breast milk. And later on, they found that children who have mothers who smoke actually have a higher incidence of asthma. They have difficulties with their vision. They are more likely to have colic. So that's a lot of crying, a lot of abdominal pain. They're also more likely to have bone fractures and childhood obesity. So there are quite a few risks right from the time of conception, all the way through pregnancy, through delivery, and then even as the child grows up. And you must remember that the child is also being exposed to secondhand smoke, perhaps, right? So pregnancy actually is one of the biggest reasons for women to stop smoking. So about 54% of women who smoke before pregnancy quit smoking directly before or during pregnancy, which means that pregnant women do want to quit at this time. And perhaps that is one of the ways that we can intervene, right? So they do want assistance at this time, they do want to quit, and they're probably aware of certain risks, but they're unable to. And this is a good time for us as mental health practitioners to kind of help them out. NRT is a very safe and economic option, but sometimes adherence can be difficult with replacement because the individual would have to take a gum or a patch, and there's always the issue of some side effects. So we have some limited data on varenicline and bupropion, but the data is quite limited. So a lot of practitioners don't always give this. But one good thing about both these agents is that there is no evidence of fetal anomalies or teratogenicity, which means that a lot of these misconceptions that medications are bad, but the smoking should be all right, is something that we can actually work on correcting, right? In the postpartum, it's important because the child may be exposed to secondhand smoke. They may have sudden infant death syndrome, a lot of respiratory issues. They may have ear infections. Also, they found that mothers who are actually smoking have decreased fat and protein content in their milk. It may also actually hamper the taste of the milk and the way that the babies gain weight after pregnancy, after the delivery. And perhaps what we can do at this time for pharmacotherapy is use the lowest doses of NRT, and perhaps also bupropion is a good option if the mother is lactating. We have limited data when she's pregnant, but when she's lactating, then bupropion is a good agent for that. So, one of the interventions that is probably very important and quite logical in someone who's pregnant or just delivered is that you're going to have a multidisciplinary team, right? You're going to have obstetricians and gynecologists on board. You're going to have psychiatrists or addiction experts, psychologists on board. So, it needs to be a team effort. It's very important to give them personalized feedback. And of course, we're going to use medication and psychotherapy to help assist this woman to kind of, quit smoking during this very important time. Lastly, I'm going to talk about elderly. And what we found in a recent paper is that 41 to 45% of urban and rural older adults in India use tobacco in some or the other form. And the global prevalence in 2015 for any adult over 65 years was 25 to 38%. So that's about a third of every individual who's above 65 using some form of tobacco. So that's quite a large number. And perhaps why tobacco use is so common is there's something called survivors and there's something called reactors. So when someone is an elderly individual, I could be someone who's already been smoking for pretty much my entire life, and I continue that smoking. So that's a survivor. And there's also reactors. So, I haven't been smoking, but then something pretty terrible has happened. I have developed a chronic illness. I have a comorbidity. I have so many medication. I have social isolation. I've lost someone very important, or I feel perhaps quitting at this stage would not really do me much benefit or do me much harm. And when someone actually starts to initiate substances after a traumatic incident, and they actually kind of initiate the substances while they have already achieved an age of 60 or 65, that would be called a reactor. And both of these kind of things are of course dangerous, but survivors actually accumulate risk over the years and years that they've used tobacco. So perhaps they are at slightly higher risk of developing the various consequences on health, which includes a chronic obstructive pulmonary disease, cardiovascular disease, cancer, stroke, you name it. Of course, it also impedes the quality of life, and it also actually adds the burden onto the chronic illness. It probably also interacts with a lot of the medications that elderly people are already on. So, how we can actually intervene with people who are elderly is to have tailored cessation programs. And what I mean by this is maybe this individual can't come in very often. Okay, maybe they need to have more spaced follow ups. Maybe I need to meet them online, or I need to give them something that they're going to find feasible in their daily life. So if they're edentulous, they don't have teeth, then I'm not going to be giving them nicotine gums, for example. Then I'm going to have to look at patches, right? So something like that. So it needs to be quite tailored to their needs. I also need to consider their physical and cognitive limitations. So, is it even possible for them to come in for a chat? Is it possible for me to do a CBT program with them if they're not going to be able to engage in that? Right. So this is something that we need to keep in mind, especially when we're dealing with the elderly. Addressing misconceptions, like I said, a lot of people say, I've been smoking for about 30 years. It's too late to quit. I cannot quit now. It's physically impossible for me to quit because I started really early and I've been smoking my whole life. Or there's no added benefit for me in quitting now because I've already done the damage, So there are a lot of these misconceptions. And as providers, we need to know that at any point of time, if someone stops smoking, it greatly improves their circulation, their respiration, and all of that, right? Also, understanding drug interactions, helping them to build social support because that really helps. And it's one of the risk factors why they started to use tobacco in the first place. And of course, pharmacotherapy. So, both the medications, varenicline and bupropion, are used in the elderly. Bupropion is even better if someone is suffering from geriatric depression. So that could also act as an antidepressant. And then, you could also use it for nicotine cessation. And of course, you can use nicotine replacement therapy, quite safe, no interactions or anything like that. So I guess my takeaway would be that tobacco use is something that's pretty ubiquitous. It's licit. Everyone, it has access to it, and tobacco use is very, 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 very prevalent. And the same stands true for all of the special populations that we spoke about today. But what makes these special populations different is that they're more vulnerable, they're more impacted, and perhaps their assessment, evaluation, and treatment is a bit challenging. So either they're underdiagnosed, undiagnosed, or untreated, and probably as mental health practitioners, we need to be a little bit more proactive whenever we encounter a special population case. So that's about it. I hope I've done well on time.